So again, I'm going to talk on this presentation on my concept for neck lift surgery. I want to, and that's why, I put this word understanding the importance. I think in this sort of, kind of presentation we're going to go through in the next 45 minutes, I want to sort of, for you mostly to understand the concept of why we're doing this, more on the sort of technical details, which I think that unfortunately I couldn't cover everything on this time frame, but definitely I'm trying to decide what was more relevant. I think that if you understand something, a lot of times it's better to understand it and understand the reasoning behind it and the importance, and then the other surgical part. I think that most surgeons can learn, especially with a good background in reconstructive head and neck surgery, which I'm aware that most of you here in the Netherlands have an outstanding reconstructive background. Have no conflict of interest. This is the study I was mentioning before by Reha Yavuzar from Turkey about the areas that concern the most in females from ASJ to 2012. And definitely when females age, initially, it's the nose, the area that bothers them the most, periorbital region in their 40s, but definitely after 50, it's really the jawline that's very, very important for these individuals, right? And when you look at a profile of an artist trying to portray a profile of an attractive and young female, you would think they would draw that, and of course we know if you have any art background, you would never draw this, right? The way you would draw this is like this. And you think, oh, it's a little detail. It's a huge difference, okay? So this I call the extended submental line. And this really is what gives you a contour of the jawline and attractiveness, right? And photographers know this. So this photographer, when he was using lighting to try to portray the attractiveness and youthfulness of these models, he's using that lighting to cast that shadow on the jawline so that that area is really something that is an attractive feature for these individuals, right? And when I tried to do this, okay, so I said I took this sort of image, and you might say, okay, what you did here is just draw this with an imaging software program. I actually did not draw it. What I actually did was take a real 3D model on on a 3D modeling software, in this case Cinema 4D, but you have Blender, for example, and I actually took lights. I took a rim light and a disc light, a spotlight, and then I was able to cast shadows on the program, and these programs are incredible. They're using real physics, real lighting with rebounds of the light, and you can get in real time some of these programs. This is Marmoset Toolbag, another program. You're getting rendering in real time of your shadows and lighting, which is an incredible tool. And you can use these like laptop computers. You don't need a super powerful computer. These have advanced so much, and the graphic cards in these computers are so powerful. You can actually do rendering in real time. And it's very important for us because remember, we're artists. And for an artist, this is Francisco Goya in the Prado Museum. He used to say that he would only see forms that are lit up and forms that are not. There's only light and shadow. And Leonardo da Vinci, the greatest artist in history of mankind, he would say shadow is the means by which bodies display their form. The forms of bodies could not be understood in detail, but for shadow. So we need to understand lights and shadows, right? And Leonardo was obsessed with lights and shadows. He went really wild with lights and shadows, okay? So we need to sort of do that and understand how important those shadows are to define the jawline. Because normally people are kind of only focused on the submental cervical angle above around 100 degrees, right? And if you have someone, and if you just reduce like zone 1 here underneath the chin, you will make them look better, okay? So I understand that if you want to improve that angle and you want to have a better shadow there underneath the chin, you can put a little chin implant, a little liposuction. They'll look better, okay? But look at the difference between that, okay, good, and this. Now, that's a game changer. That's a game changer for your patient. If you have that definition, that shadow underneath the full length of the jawline, not only underneath their chin, right? And unfortunately, you cannot see those angles on the profile view. You need to see that posterior lateral submandibular cervical angle. You need to show a posterior cranial 3/4 view or an anterior caudal 3/4 view. That's the only way to see those angles, right? Because the only way we see them is through shadows, okay? So the only way to see that on the table result here is by looking from posterior cranial and see that angle that has changed from before and after, or show in profile view and you can see an improvement of the shadow that was formed there, okay? Because we have depth, we have separation between your face and your neck, and that's how you have a shadow underneath your mandible. So again, my objectives are getting a nice shadow underneath the full length of the mandible, and I do that by addressing the lateral submandibular cervical angle, which is only visible on the anterior caudal three-quarter view, okay? That's the way to see if you change that angle. And this is my first paper, 2013. This is the other paper I wrote in 2018 on clinics and plastic surgery, where I set up all of these sort of algorithm in order to reduce these submandibular structures to achieve maximum definition of the jawline. So I separated the submandibular region in 3 zones, 1, 2, and 3, and I sort of described the structures that needed reduction in order to achieve that separation. But looking back at that paper, I think the most relevant contribution there is really the description of the lateral and posterior submandibular cervical angles. Because up to that point, the only angle described in the neck was the anterior submandibular cervical angle, or the submental cervical angle, described by Ellen Bogan many years ago, okay? And those other angles are very, very important, okay? So this is sort of my approach to neck lift surgery. I separate my work into volume contouring, which is deep work, and superficial work, which is skin muscle redraping. So most of this presentation will be on my deep work. I wanted to include a little part of my superficial work, which I think is also relevant. But what I want to really sort of encourage you very much to separate those two kinds of techniques, because you might see on YouTube, surgeons pulling on that skin and showing with a little forceps. Look at the effect I get over there on the neck just by pulling on the skin there. And we know that's not going to last, That's not going to last. It's like trying to, hold all of that, just putting like a tight shirt, okay? That will hold a little bit, but you know how thin the platysma is in the skin. That's not a structure that's going to hold any volume, no matter how tight you pull on it, okay? The first one to show this, really very elegantly, was actually Fuad Nahai in his 2004 paper in ASJ, where he said reconsidering neck suspension sutures. And he shared with us how he was really cut back with his initial enthusiasm with the Jampapa type sutures, trying to hold or hold those sort of deeper structures. And he said that he realized that over-operating in the superficial planes to improve deeper problems did not produce long-lasting results. And we know that, okay? And you might be able to get like a nice image at, even I think I was talking with Jerry O'Daniel about this, that you might sort of get even up to like a 7-8 month result where you can see that that holds up. But anywhere after that, so if you're able to snap a before and after without any deep work, just by a strong lateral pull, before 5, 6, 7 months, you will see some improvement. But I think long term, there's just no way. And actually things come back, things come back with time, and I was asked by the journal to discuss this paper by the UCLA surgeons. They're great. I know them very well, Jason Rustanian. And they did this paper about whether the gland was ptotic and failed or it was growing with aging, with the conclusion that, it was sort of there was some ptosis, and that sort of with that sort of kind of implying that you can do some sort of procedures to bring the gland back into the floor of the mouth or into the mouth where the tongue is. We know there's no space there, right? So I think that we have to understand, and these are some of, editorials. I write sometimes a lot about innovation in our specialty. But one of the papers that I wrote here, I talked about the 3 stages of our specialty of aesthetic surgery. So definitely the first stage was about, just improving things that were very outright wrong in aesthetic surgery. So you have a big hump, so they would just remove the hump. You had no breast, you just put something there. That's great. So patients are better at that. Then we noticed that produced a lot of surgical stigma. So the next stage of our evolution was trying to avoid surgical stigma, avoiding the inverted V deformity, and all of these problems that we created, and that was the next stage. The third stage, which we are right now, is not only taking into account the static position, but also the dynamic position and the movement. So now for breast, it's important to have, not these big textured breasts. We'll see that, tomorrow, the breast surgeons, that don't move and that they look like in the picture, and then, Dan Del Vecchio called like the Barbie doll breasts, They look, because they're very stiff there. You want something that moves and behaves natural. For the nose, we're going to see this evening, rhinoplasty surgeons are moving a lot to preservation rhinoplasty because they don't want a big structure rhinoplasty, and patients will move, will interact with their significant other, and they will feel like a dagger there that it's stiff, that's not natural with movement. So in the face, it's also very important, the neck. Patients will move their neck. And they will flex their neck in public. And we have to understand the dynamic anatomy of the neck. It's very important. So when you have a cadaver and you remove the skin, the fat, and the platysma, when you move that neck up and down, you will see that the gland and the muscle really shift downwards. So see, this is the digastric belly of the anterior belly of the digastric muscle. It really bulges down. Everything bulges down. And you might say, okay, Francisco, what you're doing is in a cadaver, you're removing the skin platysma, everything is going to bulge down. So what I did was I took a real individual and I did a parasagittal MRI. And notice here that the structure you see the most, even in a very thick, heavy neck like this, is the submandibular gland in zone 2. And I went ahead and I did what's called a dynamic real-time MRI. This is used by orthopedic surgeons to diagnose herniated discs that don't show up in a normal view, and just in a specific moment, they just pop out a little bit. And I used it to show how much that submandibular gland shifts downwards when we flex our necks. Look how much it goes down, and look how thin that platysma is in this heavy neck. And there's not much fat laterally there. All of that volume is the submandibular gland. Look at that portion there below the mylohyoid. Look how far down it's going. It's almost going to the cricoid cartilage, okay? So there's no way really that when patients flexing their neck 1,000 times a day, and nowadays with phones, most of the day they're flexed, right? It's just a way that everything is being pushed down. There's no way you're going to be able to get rid of that volume working against your platysma every day. And again, we have to understand the surface aesthetics of the attractive flexed neck. This is very important because, again, you have to have a nice extended submental line with a nice shadow going through the full length of the mandible, and you have a single crease neck, not a double crease neck when you flex, okay? And you might think, okay, I had this discussion with my good friend Mario Pellicciaravolo. He was saying, okay, Francisco, you can have a V-neck or a C-neck that he brought up. And of course, you can have young models that have a very sharp angle here, and they have what he calls a V-neck. But you can have attractive individuals that are also young with more softer contours or a C-neck, right? And of course you can. This is a 5-year-old. And of course he has a nice and soft kind of neck, but every neck that is natural and that is attractive and young, when it's flexed, it'll always convert into a V-neck. Always convert into a V-neck, even though they're a C-neck in a profile view. When they flex their neck, if it's a natural and young neck, they will always convert into a V-neck, and they will always have a single crease neck. So what happens if you try to imitate this in a facelift? This is done by one of the best plastic surgeons recognized in the world that doesn't do deep neck work. And he achieved quite a nice result with a nice soft contour on this lady. But look what happens when she flexes her neck. This is a double crease neck. This is a giveaway. This is sort of like happening so much in neck lift surgery today because, yeah, it might look well in static, but when they look down, all of a sudden you get this deformity that's sort of like an inverted V deformity for rhinoplasty or alar notching or a suprabeak deformity. It's just something that happens with the technique. And if you know anything about art, this is the Hogarth book. This is sort of like the Bible for artists in terms of drawing and painting drapery. There's this thing called bend wrinkles, and it's the way that drapery behaves when you bend a joint, right? And if you think about this, when there's volume, like in your hand, the PIP joint is a double crease joint, always, because it's a lot of volume there. You have a thick volar plate, and you have two tendons going through there. The DIP joint is always a single crease joint because you only have one tendon and you have a much thinner volar plate, right? So again, volume affects the way the superficial structures drape over your deeper structures, right? So it's important to take this into account. So this is my approach for volume recontouring. Again, we know from a lot of these studies that when you do an MRI or a CT scan, most of that volume, even in these thick, heavy necks, is just the submandibular gland. There's no volume really laterally on the neck in terms of fat, okay? So what I do is I remove the subplatysmal fat. I normally leave a good amount of subplatysmal fat over the hyoid area and the undersurface of the platysma. In males, I might remove a little bit more because I might want to have them a more visible Adam's apple. That's part of what's called sexual dimorphism, which is making males look more masculine and females look more feminine, and this has been shown that that has an impact on attractiveness, right? So males I might remove more, but females I want to leave plenty of fat there to not look overdone or over-skeletonized. And once you remove that, then you have to address the next bulge laterally, which is the submandibular gland, and I will reduce the lobe that's caudal to the mandible. And the lobe that you have to reduce is sort of what's hanging over the mylohyoid. So, you know, the gland sort of goes around the mylohyoid, so there's plenty of gland that goes into the base of the mouth around the mylohyoid, and you just need to address, you know, what's really in that plane, following your mylohyoid plane, and just reduce what's sort of hanging aside from that. And you can end up with quite large specimens like these because, again, a lot of these patients really have a very low set submandibular gland. Okay, and this is what I leave behind in terms of my resection. And once you do that, you have a third structure there that all of a sudden is very visible, which is the anterior belly of the digastric muscle. And sort of it behaves sort of like a triad. If you have, you know, if you're not committed to doing everything there, you might as well not reduce the subplatysmal fat because then you're going to have a cobra neck deformity and bulging laterally, okay? And that's the specimen I removed from the digastrics. So definitely indications. So definitely the very heavy, thick necks, you need to address these structures. A lot of these patients, you can already see just from there, you can see the gland right there on these heavy, thick necks, and you can see it right there, the submandibular gland, without even palpating anything. So you need to achieve that extended submental line to achieve that reduction of the deeper structures, and again in the Connell view to make sure everything is looking good, and the three-quarter Connell view as well, and the enterocaudal three-quarter view. And again, all of these patients require deep work. If you want to have some results on these very, very difficult complex necks, it's not about just fat, it's about getting the deeper structures and reducing them in order to get these sort of results. These are very, you know, very thick, heavy, you know, not mobile necks, very, very stiff necks. And again, in order to have any sort of kind of result in these very complex necks, you need to address the deeper structures of the neck. Right. Male patients are an important population that have tendency to have perifacial expansion and cervical fullness. I did write on this, it was a great issue of Clinics in Plastic Surgery on male plastic surgery, so you'll find a chapter there by Timothy Martin on the face, and they asked me to do the one on the neck. And what I did there, you know, in males you really want to do, sometimes you can do that in males through just what's called a short scar neck lift or an anterior approach only neck lift, and some of these patients where you have to reduce all of that volume and then, well, in this case, reduce all of that volume from the central neck. Again, this is another short scar in a 40-year-old where you need to address just with a submental incision. This is my sort of oldest patient I do this on, 55-year-old. You know, males, you can get away with a short scar only submental incision more often because we have thicker skin because of the hair follicles, and that skin will redrape better. Normally in females, I would not do a short scar only in anyone older than 35 years old. And again, some of these male patients, and again, these male patients, you really need to have that jawline because again, it's a sexual dimorphism, not only the Adam's apple that it's very important for a male, but also that nice jawline that in males it's also a very masculine feature to have, and the Connell view. And again, I'm addressing the lateral submandibular cervical angle, which you can only see through these sort of views, and how I change that is why I get a nice shadow underneath the full length of the mandible. And a lot of these 50-year-olds in their mid-50s, you know, they're fit, they're healthy, but their neck is just not there. They don't have a nice, they go to the gym, they really take good care of themselves, but they have these problems here there, and the only way to have a nice, good sternocleidomastoid muscle, what Feldman used to call the musculomandibular triangle, and a good Adam's apple is by doing those sort of deep neck work. Younger patients, again, it's a population that I will often do because these patients that are in their 20s, they just want that nice shadow here with a nice sternocleidomastoid muscle and this nice shadow there. And liposuction is not going to do it long term for them, right? So I just do a little incision down here, and I'm able to achieve that little reduction there that will give them younger appearance. Even some patients like these that even have a little heavy face, I will just go ahead and do a full face and neck lift in a 35-year-old. And again, I think you can achieve really a good changing on their appearance by doing these facelifts and neck lifts in younger patients, right? And just getting it to sort of contour it very specifically without avoiding these liposuctions that long-term they might debilitate the platysma and have them, too defatted in areas that are very important, like the subcutaneous fat. Another 39-year-old patient, the same way, with a bad jawline. And notice here, she already had a right angle in the canal view. So she's already a V-neck. So it's not only about V-necks or C-necks. It's about, look at that, just by reducing this bulge here, which is the submandibular gland, look how better that shadow looks, how long her neck is, and how much, young is. She's a past runway model, that very tall woman. So she can have a nice long neck and look very attractive. This is my youngest patient, a 19, a teenager. And again, she came in asking for a chin implant, and I said, your chin is fine. Let's go the other way and get submandibular depth underneath your chin. So these are the most complex patients, the deflated and thin necks, these patients that have lost a lot of weight. These are very complex because they have volume issues for sure, but definitely the superficial tissues are very important as well. Patients like these, older patients, I hear a lot, you can't do a face neck lift on an older patient because anyone above the age of 40 has to have a bad neck or else they look, artificial. I don't agree with that. I think the 70s are the new 50s. This is a retired, American living in Spain, and he takes care of himself. He's nice and fit. He's healthy. He's thin. Why not have an excellent neck and jawline? He does. He in his body, he looks great. So you can give these individuals a nice-looking jawline and neck, and it's not wrong. It's not wrong to do it. Okay. And again, these patients, this is a 2-year post-op result after reducing deeper structures and redating superficially. And I tell my patients that neck surgery is long-term. You don't have to redo it. Sometimes for the face and jowls, you might have to do a little tightening after maybe 10 years. This is 7-year post-op. It really behaves very well long-term when you're done a job. A patient like 75-year-old old again. Again, she looks very natural. She had a very large gland. She was a ballerina dancer when she was younger. And you can get natural results in these patients by addressing the deeper structures and also taking care of the superficial problems. And again, this is another example of patients that need both. You need to address that superficial tissue, but definitely treat the volume underneath because, again, that volume is pushing on the superficial, and I would not get this redraping if I would just pull on the skin and platysma here laterally. No way I could get these sort of results on these necks if I did not address the deeper structures of the neck. Again, very thin patients. These, for me, are the most challenging, even more challenging than a big, bulky neck, which might look more spectacular. But to get these necks right, you need to address the volume, and you also need to redrape and do something for the superficial patients. Like this, again, very thin skin, very problematic, but also she has volume issues here. And the only way to get that nice shadow here over there is by addressing this volume that's sort of, making all of this skin have all of those wrinkles there. Okay, I'm going to briefly, in the last 20 minutes, just talk about the superficial work. I do a dual plane, what I call a dual plane neck lift and skin muscle redraping. Again, I published this in this paper from 22. It's about male surgery, but most of the concepts about my dual plane procedure are there. And these are the key maneuvers that I do to manage and avoid and minimize recurrence of platysma bands, which is a big problem for the neck lift and facial rejuvenation surgery. So there's 6 steps. We went through reducing deep volume. Again, reducing deep volume is very important also to affect your superficial work, because what we were saying before about the facial jowl and reducing the buccal fat pad, if you have a lot of bulkiness there, no matter how excellent you did your platysma application and everything, the moment the patient starts moving their neck, and they will flex their neck, everything is just going to hold up much worse long term, and it's going to fail long term. So you need to address that. The thing I do is I do a full thickness transection of the platysma and deep cervical fascia, full length, full thickness, and I bring the cranial platysma medially and the caudal platysma laterally. And by doing this, what I achieve is what I call the 3D Z-plasty. So in the three axes of space, the Z, the X, and the Y, I'm able to separate the platysma. That platysma band, I'm able to separate as far away geometrically as you possibly can, which is by doing a Z-plasty. In fact, that's why the Z-plasties work in reconstructive surgery, because that's the way to geometrically separate a scar edge the farther away physically that you can possibly. So again, this is sort of the initial way on the right side. On the left side, what I achieved by that sort of getting the cranial platysma medially and the lateral platysma laterally and completely transecting that. This is a patient that I had a previous failure with a neck thread lift. This is the scar they tried to place there. And I know here in the Netherlands you've done excellent work on demonstrating these problems with thread lifts. And again, then this is after doing this technique. Other patients with, again, very thick, heavy muscle platysma bands, and I think you can really get a nice result around these bands and very low recurrence net, problems. Look at this thin skin also, how you can improve it by that neck lift. And again, very thick, heavy platysma bands, and you can improve that by addressing this with that 3D Z platysma concept with a very, strong banding there anteriorly and getting a nice result in getting rid of those platysma bands laterally. Finally, what I do, a couple of steps that I want to go through on my superficial work is what I call the caudal cervical thick composite subfascial flap. So I did cover this in my paper. I do a dual plane technique, meaning in my submandibular segment, so I have a line that's very important for my planning, which I call the SC junction line. That's where the submandibular segment of the neck meets the cervical segment of the neck. And that line is very important because everything below that, I will go deep. I will go deep to the platysma and deep to the deep cervical fascia, and everywhere above that, I will do subplatysma anteriorly and subcutaneous as well. And again, this is another illustration. We're working on the Mendelssohn book. I have chapters there. And this is the concept again. So again, everything below that platysma transection will be deep to the deep cervical fascia. I will leave the platysma attached to the skin, and I will even go below the deep cervical fascia to have a nice and thick composite flap. And above, I will go in both directions. So this is how I achieve natural looking necks, because a lot of the problems with, delaminating all the skin is that you get this sort of like skeletonized kind of patient with like radiotherapy kind of looking. The skin doesn't look, it looks waxy. It's a long recovery. And you can leave that all attached. And in these very patients with very complex necks that are very thin, you don't want to, that muscle is so thin and that skin is so thin, you don't want to delaminate that. Look at this patient with that very, very creepy skin in her neck. And we get a lot of these patients also, right? These are very, very complex necks to solve. And you need to go with a very nice and thick flap and just elevate all of that and bring that laterally, okay? And again, this is a long-term result, 2.5 years, with very thin skin on a lot of these patients, and you need to have fullness. This is a 3-year post-op, and again, on a patient with very, very thin, crepey skin. Look at that skin there. You don't want to separate, and you get a 3-year post-op result like this with no skin treatment, nothing on the skin, just by keeping that nice and thick flap for that cervical segment of the neck. And a lot of these patients have both issues. They have volume problems, but they have very thin skin. Look at that skin caudally there. And again, look at that skin here. I mean, this is a big problem, a nightmare for us, okay? Because, again, with a neck lift, you're bringing that to the most mobile part of the neck, which is the prehyoid area. And you need to have a nice and thick flap there in order to get these sort of results. Again, patients that you might think, oh, there's just a lot of volume there. No, it's also a skin issue. Look how thin these patients are here. So you need to address the deeper volumes, but definitely you need to keep a nice and thick flap. And you won't see a lot from this view, okay? You might see, okay, problems here in the skin here, much better there, but look when they flex the neck a little bit in the 3/4 canal view. Look at these problems here. This is thin skin. Look at the anterocaudal 3/4 view. look at these problems here. That's very difficult to solve. This is a big challenge for a neck lift surgeon. And you might say, okay, this is improved. You get a nice, some mental extension line with a nice shadow there. But look, just a slight little flexion of the neck. This is where you see if you have results in facial rejuvenation surgery. Okay, again, these patients with very complex thin necks, you need to have that approach. And other patients, you know, this is a 59-year-old patient, again, showing the Adam's apple and the three-quarter canal view, having a nice contour around the neck, the anterior three-quarter view, a nice sharp angle here with a good Adam's apple in a 59-year-old. And this is even more complex. So we don't need any skin. This is a bald patient, which is a challenge for us. So I stopped my incision here. This is where I stopped my incision. And I stopped my incision there. And everything was done by deep neck work, a good superficial platysma work and 3D Z-plasty, and then I was able to redrape the skin with an Auer's valve net. And of course, I always say there's no good face and neck lift if you can see a scar. So of course, anything you do, you cannot see a scar. You cannot see a scar if you're doing if you're a facelift surgeon. So I do all my scars myself, all my closing of my wounds. I don't let my assistants close, and I use loops for closing. Because you cannot have a patient like this. That's a male patient. That's a very active businessman to have these issues. And again, this is the canal view in a bald patient without skin removal, just by redraping. And again, you can get these sort of results with a direct deep plane facelift and these sort of results. Finally, I'm going to end with what I call the caudal platysma weakening. I think this is an important concept. Again, when I'm trying to do this with this concept I'm going to share with you is I'm trying to injure the second branch or the caudal branch of the cervical branch of the facial nerve. Where does this branch lie? It lies on the deep cervical fascia. It's not underneath the platysma. There was a great paper by Charlie Thorne and Sammy Sino on how most of the techniques that transect the platysma will not injure the cervical branch of the facial nerve because that nerve laterally is very deep. It's right on the deep cervical fascia. It's kind of invested on that fascia. So by transecting the deep cervical fascia, not only the platysma, I'm able to injure that caudal branch while maintaining the innervation for my cranial platysma, because that cranial platysma is important as a lip depressor and also to hold my structures deep to the neck. I want tone on that muscle. But I want the cervical platysma to be partially denervated or weakened at least, because the platysma, if you think about it, is a flat muscle with very thin skin attached directly on it. What other muscle is like it? The frontalis muscle. Nice and flat muscle with thin skin right over it. And what happens to those muscles? You get dynamic wrinkle lines perpendicular to the direction of the fibers. So if you weaken those muscles, you will have an effect. This is the paper I was mentioning by Sammy Seen and Charlie Thorne. If you injure that branch, here notice how I'm going through that deep cervical fascia, and I'm getting that sort of action of the platysma, of the caudal platysma. If you go through and injure it, and this is actually the latest paper actually we wrote with Van de Ley and also with the Australian group on sort of this platysma anatomy. But it's very hard to fully denervate the platysma. It has so much cross-innervation, even from sensory nerves like the cervical plexus, it will re-innervate. But at least you can get to weaken it. And you can weaken it with this technique before and after. And you can get these sort of improvements on the dynamic wrinkles of the neck by doing this. So this patient with these dynamic wrinkles of the neck, this is no skin treatment done on her neck. No skin treatment at all. And of course, remember that we did the lip for her. But look at that. No skin treatment on her neck. This is just platysma weakening with that transection of the deep cervical fascia over there. So all of that is done with that weakening of the platysma in order to get those results on the neck. Notice the neck. Look at those horizontal dynamic wrinkle lines here in the anterior neck. Look how all of those have disappeared with this technique. No skin treatment at all placed on the neck. Nothing done on those wrinkles. And again, an older patient in his mid-70s. And again, a patient that takes good care of himself. He's healthy. He's fit. And he can have a nice looking neck and jawline, no problem at all, okay? And again, this is a 2-year post-op result with no skin treatment at all. And 2-year post-op, she had a previous thyroidectomy scar, no skin treatment at all. And this is a 5-year post-op result, no skin treatment at all. And just to finalize, I want to mention that the moment we're living with the success, this is another great discussion paper by Stru on the direct and tell paper on twins, where he was mentioning that because of the success nowadays of injectables and of the neurotoxins and fillers, a lot of the patients that are going to a plastic surgeon complain more about their neck. It's really the neck, because they look great around their face. They take good care of themselves. They tried everything. They look very good around their face. So when they're coming to you as a plastic surgeon, you better deliver a good result around the neck. So again, I think history, I like this quote by Mark Twain, history doesn't repeat itself, but it sure does rhyme. And if you look back on papers, and Jose Guerrero Santos, who was, I think with Ivo Pitangui, one of the sort of visionaries of our specialty from Guadalajara, Mexico, he said in 1974, he already said that his patients worried more about the physical changes in the neck than those in the face. And the surgeon performing facelift should use all the ingenuity and skill to obtain an optimum result in the neck. And this holds true more than ever now with all of these procedures coming up around the face, non-surgical. And I like the book by, I had the fortune of spending some time with Joel Feldman in Boston, and he wrote this book, Neck Lift, which is of course sort of the landmark book on neck rejuvenation. And he was doing deep plane facelifts when I went to visit him in like the early 2000s. And I was waiting all the time for the second volume of his going on the facelift. Never came. Never came. Why? Because the neck lift is really what's important. And I think that in facial rejuvenation surgery, the face is overrated. Everything is about the jawline and neck. And yeah, you can do the lower face pulling here, but really the central face is more about volume. It's about skin. It's about skin and volume. And this is, for example, crotch and oil peels. I really like them, just like Dr. Nahai was mentioning before. You can really change the skin on these patients with crotch and oil peel. Actually, I just saw Richard Benjamin here before that he was here in Amsterdam. He's, Heder is the first one to really advance the science of crotch and oil, but definitely the finesse of everything was done by Richard Benjamin and ASJ. I really recommend those papers. But you can really change these individuals around the face, with these sort of peels. It's not about a facelift, it's about the skin. And then surgically, yes, you can do a lip lift, you can do, eyelid surgery, a brow lift, but definitely where we need to deliver results is around the neck and jawline. So definitely I do think that the neck lift is the new facelift, and I think that we should really focus on this area. Thank you so much for your attention. Thank you very much.